Dr. Hirsch sends his regrets. Can't be here today, so it's my honor to welcome you all. I'm going to start with a land acknowledgement to acknowledge that we are on the land of the Ramaytush Ohlone people, who are the traditional custodians of this land. And we pay our respects to the Ramaytush Ohlone elders, past, present, and future. They call this place the land that UCSF sits on their home. And we are proud to continue their tradition, and we're honored that we are actually in this place and we continue their tradition of coming together and growing as a community. We thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. And I always like to say that these land acknowledgements are really meant to acknowledge the fact that we are here, and everything that we're able to do here builds on work and stewardship from people who were here long before us, and without them, we wouldn't actually be here. With that, I'm going to now introduce our speaker for today, Professor Teresa Kortz. I have known Professor Kortz for quite some time now. Typically, I don't call her Professor Kortz, I call her Teresa, but for this special occasion, I'm really going to call her Professor, and I should call her Dr. Kortz, because she's not only a physician, but since about a couple of weeks ago, she also has her doctorate in global health. Dr. Kortz did her, she is a pediatric critical care physician here at UCSF. She did her critical care training at Stanford University, but was then very wise to come join us shortly after that. She spent a little bit of time at UC Davis while she was doing her master's in global health here at UCSF. And I think we have Dr. Feynman to thank for convincing her that that was a silly commute to make on a regular basis, and better to just come work at UCSF and do her studies at UCSF. She joined us on faculty, I think around 2015-ish, around the time that we came to this new hospital here, has impressed us all tremendously with her great clinical acumen, but even more so with her fantastic work in global health. And that's what she's going to come and talk to us about today. Professor Kortz.
Thank you very much. That was an amazing introduction. And I have to say, I'm really honored to be here today to share some of this work with you, and specifically on the burden of pediatric critical illness in resource limited settings. So I have no conflicts of interest to disclose, but it is a New Year's resolution of mine to get some in the new year. Here's what we'll be talking about today. I hope to give you an overview broadly of the global child health kind of agenda. And then I want to go through a series of studies that we did specifically to estimate the burden of pediatric critical illness in resource limited settings. And I'll give you just a little bit of a taste of what's more to come and how we kind of take the big picture and start to focus in on what's really going on. And then, of course, wrap it up all nicely at the end. I can't, thank you. I can't control that. All right, here are our learning objectives. By the end of this talk, I hope that you can understand differences in child outcomes by global region and socioeconomic level, be able to compare causes of hospital mortality and acute critical illness by region and socioeconomic level, and explore potential reasons for the observed differences. So with that, let's get started. So I think that the modern global child health agenda really started with the Millennium Development Goals. This is a set of 8 goals that the United Nations put forth in the year 2000 that was approved by member states, and it really aimed to improve health equity and outcomes worldwide. And the target 4A was the one that specifically aimed to reduce by 2/3 the under 5 mortality rate by the year 2015, starting from the 1990 levels. The good news is that we were able to decrease all-cause mortality in every region of the world within that period. We went from an absolute number of 12.7 million to 6 million child deaths. And we did that primarily through efforts from the World Health Organization, WHO, UNICEF, and a focus on primary preventive care, breastfeeding, nutrition, hygiene, and vaccination. Unfortunately, at the end of the MDG era, we were still left with a huge gap. Not only did we not reach our target, but there were wide health disparities. You can see this top line that was furthest from reaching the goal was in sub-Saharan Africa. After the MDGs came the Sustainable Development Goals. And again, this was a set of goals put forth by the United Nations. And this time it was 17 interconnected goals. And the one that pertained to health was number 3, and specifically target 3.A, which aimed to end all preventable deaths of newborns and children under 5 years of age by the year 2030, so a much shorter timeline. Unfortunately, as of April of this year, at a United Nations General Assembly on SDG progress, it was noted that at the midway point on our way to 2030, the SDGs are in deep trouble, and the world's poorest and most vulnerable people are bearing the brunt of our collective failure. And the collective failure looks like this. So this is child mortality from 2019. And the countries that have reached the SDG target 3.A are shaded in green. And those that haven't are in yellow up to red, depending on how far off they are from that goal. And to put this into perspective, the under 5 mortality rate in the United States is 6 per 1,000. In Somalia, it's 115 per 1,000. So you look at a map like this, and it's clear to see how geography can be destiny, because 80% of global child deaths are occurring in resource-limited settings. So the next question is, we know where the burden is and we know how high it is, but what are the children actually dying from? And this is data from 2017 that looks at the global under 5 child deaths, from most common to less common. And I admit, I completely approach this with the lens of an intensivist. And so I look at this list, and what I see are pediatric critical illnesses. I see sepsis, I see pneumonia, and I see trauma. And these are the leading causes of morbidity and mortality outside of the neonatal period. And what do I mean by pediatric critical illness? So conceptually, acute pediatric critical illness is an acute, often unforeseen development of a life-threatening condition. And critical care, therefore, is the time-sensitive life or organ-supporting intervention that tries to divert the natural course of that disease. It oftentimes also involves continuous or frequent monitoring to try to prevent further deterioration. So that's a good conceptual definition of what I mean by pediatric critical care and critical illness. So I then went to the literature to try to better understand what is the global burden of pediatric critical illness. Unfortunately, there have been 4 large point prevalence studies globally to look at this. Despite having this great body of literature, there remains some key gaps in our knowledge, and that's based on a few core things. So one is, to date, all of the point prevalence studies have focused on single critical illnesses: acute lung injury, acute respiratory distress syndrome, neurologic injury, and sepsis. I think we can appreciate as clinicians that there's significant overlap between sepsis and ARDS. In fact, sepsis is one of the most common causes of ARDS. And so it takes similar resources as well as knowledge to be able to manage both of those. So viewing them in a silo independently, you kind of miss the bigger picture. The second major gap is created by where these studies are taking place, and it's primarily in North America and Europe. And in fact, when low-income countries are included, they tend not to be representative of the region. For example, including South Africa in the Sprout study. South Africa, from a resource perspective and a health systems perspective, is not representative of sub-Saharan Africa. And the final gap is created by who we're sampling, who our patient population is. So on the last slide, I shared a conceptual definition of what critical illness is. To operationalize that definition for research purposes, it becomes admission to a pediatric intensive care unit. Unfortunately, that criterion alone significantly disadvantages the most vulnerable population of children who don't have access to formal pediatric intensive care units. So in the end, that leaves us with no estimate for overall critical illness burden. The available literature that we have is not generalizable to resource-limited settings, and we lack a pragmatic and inclusive definition for critical illness. I think this last point is particularly important to stress. And what I'm showing you here is a picture from the oncology ward at Muhimbili National Hospital in Tanzania, which is one of my primary research sites. And it's actually settings like this where critical illness is often managed in resource-limited settings and not those formal ICUs. We're actually in a very unique position right now because the World Health Organization, on the tails of the COVID pandemic, has really recognized that critical care is an essential part of the health system and not a luxury. And in May of 2023, they put forth a resolution for near-term action for health system strengthening to deliver high-quality critical care, and that's to start in first-level hospitals. To be able to do this, however, to set a prioritized agenda, to be able to advocate for appropriate resources, we really need hospital facility level data. And here we have yet another gap, and that's that most of our large databases, especially with data from low and middle income countries, are population level estimates. This is Global Burden of Disease, WHO, and UNICEF databases. So the prevalence of pediatric acute critical illness in resource limited setting hospitals is actually not known. And so we decided to take this on, and the Pediatric Acute Lung Injury and Sepsis Investigators Global Health subgroup decided to see if we could shed some light on this. So we first developed a definition for pediatric acute critical illness that could be applied across resource variable settings. We then aimed to determine the frequency and etiology of acute pediatric critical illness and mortality in resource limited settings. And all of this was so we could provide data for resource allocation and policy decisions. So really taking that evidence to policy. The first study I'd like to tell you about is the systematic review and meta-analysis, specifically on the etiology of hospital mortality in children living in low and middle income countries. And I have to pause here to go over some important terminology, and I've already used both of these terms in the talk, but it's important to understand that there are subtle differences between them. So resource limited settings are settings that lack funds for healthcare. And that can manifest in a variety of different ways. It can look like limited access or availability to medication, equipment, supplies, devices, maybe less developed health infrastructure, or fewer or less trained personnel. But overall, this is really a subjective definition, and it's meant to be more descriptive. The other term we often use is low and middle income country, and that is a objective defined definition that's determined by the country income level. And so it's a way to broadly categorize the countries based on the resources that are available. However, you do lose the specificity to be able to tell those intra-country variations. One way you can determine country income level is through the sociodemographic index. And this was developed by the Global Burden of Disease group. So the same group that's out of IHME. So they're doing the large global burden of disease studies. And what's nice about this index is that it combines more than just country income. So it also includes a metric for education and fertility rate. So it's a better metric overall of a country's socioeconomic development as opposed to the GDP alone. And it's also been shown to be closely tied to health outcomes. So for this series of studies, we use the SDI to determine country income level, but it's so much more than that, just so you guys get the context. So in terms of systematic review study design, we chose the Cocoa Pop framework, which sounds like a very delicious musical breakfast cereal, but is in fact a framework for observational studies. And it looks like this. The framework defines the condition, the context, and the population. So we were interested in cause-specific mortality. And again, I have to have an aside here because so far I've been talking about critical illness, and now all of a sudden I'm talking about mortality. And that's because when we sat down to do this review, we realized that there is no good consensus definition for pediatric critical illness that does not include wide populations of vulnerable children. And so we decided to focus on mortality, the thought being that in a setting without formal critical care services, life-threatening illness was more likely to progress to mortality. So we acknowledge that this is really just the tip of the iceberg when we're talking about pediatric critical illness, but it was something that we could objectively measure and compare between sites. We're interested in studies published between 2005 and 2021, and we defined resource-limited settings by the low and middle income country criteria. And again, this allowed us the specificity to actually put individual countries into the search criteria. And we were interested in the pediatric population, so outside of the neonatal range. We wanted a general pediatric hospital admission population, and we excluded data that was older than 2000. And we also excluded settings that were not representative of the normal LMIC context and specialized hospital populations. We really wanted that general pediatric population. We did a meta-analysis with a random effects model and report outcomes for 1,000 pediatric hospital admissions. And then we report both overall and regional estimates. For the regional estimates, we use the global burden of disease regions. What's nice about this is it's 7 different regions, but they're categorized not only by geographical location, but also by cultural and economic similarities. So we searched 4 different databases using mesh terms and keywords, and we did both an original search and a gap search. And for people who have done a systematic review, these numbers are for you. We had almost 30,000 records identified initially, and even after title and abstract screening and removing duplicates, we still assessed over 2,000 articles for eligibility. And ultimately, we ended up with 253 studies in the systematic review. Regarding the distribution of those included studies, what you're seeing here is the map. The countries that are in white are not low and middle income countries, so we're systematically and on purpose not included in the analysis. Those that are gray are low and middle income countries, but we didn't have any data for them. And then from blue up to maroon, you can see the increased number of studies included. Overall, this database represented 21.8 million hospital admissions, 293 sites with site level data, and 59 low and middle income countries. It also included 6 of the relevant GBD super regions. One of the super regions is high income countries. And here I'm showing you the all-cause mortality. That's on the y-axis as a proportion, and along the x-axis, you can see the various GBD super regions. And you can immediately see that there's huge variation in all-cause mortality, and South Asia has the highest rate. Across all low and middle income countries, the all-cause hospital mortality rate was 4.1%. Put that into some perspective, in the United States, it's less than 1%. Our primary outcome was cause-specific hospital mortality in children. This is a very busy figure, so we're just going to walk through it. On the left-hand side, you can see the most common causes of hospital mortality by organ system from most to less common. The numbers in parentheses are the numbers of studies that contributed data to that point estimate. Next is a forest plot, which shows the point estimate, so the prevalence per 1,000 admissions. And then we provide both the overall and the regional estimates. And what you can see is that the top 3 causes of mortality in low and middle income countries are still infections, respiratory conditions, and gastrointestinal conditions. But there's also significant variation between the different regions. So if you dive a little bit deeper and look at the specific diagnoses that are causing mortality, here we have a heat plot as well as a similar setup as the last figure. So on the left-hand side or left column, you have the diagnoses from most common to less common and the point estimate in the middle. And then we have both the global and the regional rankings again. And the top 5 players are malaria, shock, malnutrition, pneumonia, and sepsis, which are things that we've seen throughout global child health for sure. But a few things that are a bit striking. One, that malaria is still number 1. And not only that, but it's really being driven by just the malaria endemic regions. And that's enough to account for the greatest overall burden of mortality in hospitalized children. The next thing I think that stands out is the fact that malnutrition is number 3. This is despite the efforts of the MDGs that really focused on nutrition, hygiene, and breastfeeding. So we clearly still have a long way to go there. We're then interested to look at the cause-specific case fatality rates by income level. And the thought here is that if you have something like pneumonia, it is the pathogen and the pathogenesis is basically the same, regardless of where you are. It's also universal. Every region in the world has cases of pneumonia. So if you're looking at outcome differences, you're starting to think about what are the other things that could be impacting the child health outcomes. So taking pneumonia as the example, you can see that the case fatality rate is highest in the low income countries. And then as country income level increases, the case fatality rate drops. So that really implies that there's more to the picture, and specifically that it's about resource availability and access to care that are impacting child health outcomes, at very least in something like pneumonia. And this has been shown before, actually. So a large systematic review by McAllister looked at severe cases of pediatric pneumonia and case fatality rates. On the y-axis, you can see case fatality rate as a proportion, and on the x-axis, you can see year. And for every question?
One slide.
Sure.
malnutrition, if I read it right, was even across all incomes.
Yeah, it's interesting.
So that is surprising, especially in light of what you just said about pneumonia and resource limitation.
Yeah, I agree. We didn't see that trend in all conditions, but we did see it in pneumonia, meningitis, gastroenteritis. The other thing I think that's interesting about that is usually the malnourished children have some degree of diarrhea and gastroenteritis. And we did see that trend in diarrhea, but we didn't see it in malnutrition. So I agree. Yeah, it's interesting. We'd have to do further analysis to really understand it. The effect in pneumonia has been seen before. So what's shown in the red dots are the low income countries. And for every time point, the case fatality rate is higher than the middle income countries, which are shown in blue. We saw something similar in severe sepsis and septic shock, where the developing countries are in orange and the developed countries are in gray. This study also showed that the odds of fatality were 4 times higher in developing versus developed countries. So I shared with you that one of our challenges with the systematic review was that it was very hard to find a consensus definition for pediatric critical illness that we could apply across settings and sites. And so that inspired a modified Delphi to actually define acute pediatric critical illness for research across resource variable settings. And Dr. Anita Arias out of St. Jude, she's a pediatric oncocritical care physician, really led the efforts on this one. There are 3 phases to the modified Delphi. The first was developing a framework with both domains and subdomains. We did this through a literature review and focus group. And the first domain is physiologic instability with domains abnormal physiologic parameters and vital organ impairment. The second domain is support requirement with subdomains, need for frequent monitoring and need for time-sensitive intervention. And with this framework, we then subjected it to evaluation by expert consensus. The expert consensus included 109 experts from 40 different countries with a wide variety of professions. We had pretty even representation between high income countries, upper middle, and low middle income countries. And you can see from this map where the experts came from by both region and country. And kind of remarkably, we had a high participant retention rate at 89%. So the modified Delphi process works such that the facilitator gathers information from the pool of experts, and then there's a series of rounds in which the experts are able to respond and give their feedback. Then the facilitator takes that feedback and then aggregates the responses and shares it with the group. And you keep going through this iterative process until you align upon a consensus definition in this case. And we were actually fortunate and were able to reach consensus after only 2 rounds. And here's the final phase, and that's the definition. So the definition is an infant, child, or adolescent with an illness, injury, or postoperative state that increases risk for or results in acute physiologic instability. And that's defined as abnormal physiologic parameters and or vital organ dysfunction failure and or a clinical support requirement, which includes need for frequent or continuous monitoring and or time-sensitive intervention. So this includes both organ dysfunction, which happens regardless of what resources are available, but also includes a clinical support requirement when those resources are available. Now, there's an additional 28 statements that go on to operationalize each of these domains and subdomains so they can actually be applicable in a research setting. With that in mind, we then took on a point prevalence study to measure critical illness in low and middle income countries and resource limited settings. And this study is called Global Parity. It's a multi-centered international prevalence study. And we had 4 different time points over the course of a year. There were 24-hour sampling frames, and the goal was to capture every child who was presenting within that 24-hour period to a hospital with an acute complaint, whether that was through the emergency department or a direct admission. And we enrolled sites that were resource-limited hospitals, and they had to meet criteria through a hospital resource survey, as opposed to low and middle income country GDP criteria. We were interested again in that pediatric population, this time with any acute illness or injury. And our primary outcome was acute critical illness. And keeping in mind the DEFCRIT definition, we operationalized that to mean within 48 hours of presentation, acute instability resulting in death, having a clinical support requirement, so needing non-invasive ventilation, invasive mechanical ventilation or vasoactives, or need for increased monitoring or time-sensitive interventions, which we operationalized as admission or transfer to an intensive care unit if it was available, a high dependency unit, or another facility for a higher level of care. And then we followed admitted children for up to 30 days for their hospital outcomes. We provide descriptive statistics by country income level, and then also did a multivariable logistic regression. And here are the global parity participating sites. The global burden of disease regions are highlighted in different colors, and you can see the individual countries as well as the number of sites per country. The gray scale is indicating the country income level, again by SDI criteria, from low to high middle income. Here are participating hospital characteristics by country income level, and a few things stand out. So one is that this was primarily a public urban academic center cohort of hospitals. And I think that really speaks to the centers that are able to participate in research in resource limited settings. And the other thing that's interesting is that 65% of them reported having a formal pediatric intensive care unit. Now, pediatric intensive care units are quite different though in terms of who staffs them and resource availability. So this was a self-reported, we have a formal unit. There's still wide differences between them. And you can see even within income level, 50% of low income countries had a PICU, whereas it was 90% in the high middle income. Now, to the earlier point, however, I found it particularly interesting and relevant that almost all of the sites reported that they had the capacity to deliver non-invasive ventilation, invasive mechanical ventilation, and vasoactive support. So back to that point that that critical care is being delivered outside of those formal pediatric intensive care units. We screened over 11,000 patients and ended up with 7,457 who were enrolled. Most of those came in through the emergency department. Almost 1,100 were direct admits. All told, we had 2,653 patients who were admitted that we followed for 30-day outcomes. The majority of patients were discharged alive from the emergency department or the hospital, although we did capture 19 deaths in the emergency department and 49 in the hospital. Our primary outcome was pediatric critical illness, but it's a composite outcome. So in addition to looking at the overall proportion of children with pediatric critical illness, we also wanted to see what criterion was the most common. And it turns out it was actually this need for increased monitoring and time-sensitive intervention. So a transfer to a high dependency unit or an intensive care unit. And here you have pediatric acute critical illness along the y-axis, and on the x-axis, you can see country income level. And it's immediately apparent that low-income countries have by far the highest proportion of pediatric critical illness. Across the entire cohort, that was 13%. For the subjects, for the actual patients who are enrolled in the study, it was primarily a young population, so under 5, and then among the children less than 1 year, that age group had the highest proportion of critical illness. We use the LOD score, which is a simple 3 clinical sign score to equate with severity of illness. So essentially, if you have 0 warning signs, that's the best. If you have 2 or 3 warning signs, that has a higher probability of mortality. And it's not surprising that severity of illness was associated with critical illness. And as the warning signs increased, so too did the proportion with critical illness. We also looked at comorbidities, and this is, again, keeping in mind this is resource limited settings, but this has some results that echo what we saw in the systematic review, which is that malnutrition was the most common comorbidity across all of the sites. However, within the comorbidities, it was sickle cell disease that had the highest proportion of critical illness. However, having any comorbidity at all, regardless of what it was associated with increased critical illness. Then looking at both region and sociodemographic level or country income level, Sub-Saharan Africa had the highest proportion with critical illness, as did the low-income countries. We're then interested to know, though, does the low-income countries, when you adjust for other potential confounding factors and contributing factors, is it still a risk factor for critical illness? So we did a multivariable logistic regression. And low-income country, even after adjustment for age, sex, severity of illness, and comorbidities, has an adjusted odds ratio of 1.86 for critical illness. So there's something about the income level that's not reflected in severity of illness and comorbidities that is contributing to the critical illness picture. Similar to the systematic review, we made a heat map, again with the most common diagnoses along the column on the left, and then we provide an overall ranking. And then instead of a regional ranking this time, it's a ranking by income level. And you can see some of the same players that we saw before: pneumonia, sepsis, malaria. Injuries and trauma this time do make it into the top 5, and diarrhea and gastroenteritis are still there. And injuries and trauma are really being driven by this demographic shift that we've seen in this country as well, where everywhere on up from the low income countries, now it's the #1 cause of pediatric critical illness, but it wasn't for mortality. Then looking at the cumulative all-cause mortality and the time to death by country income level. On the y-axis, you can see the cumulative proportion of death. On the x-axis is the time since presentation in days. We're looking at it by country income level. So the high middle income countries are in black, which actually is so close to the x-axis, you kind of lose it there. And then the middle income is in red, the low middle income is in blue, and the low income is in gray. And you can immediately see that there's huge disparities in health outcomes by country income level. And then this line shows the 48-hour mark. And I put this here to show that the majority of deaths are happening very early after presentation to the hospital. And I really think that it's this population of children who would most benefit from basic critical care services. So what I'm talking about really is avoidable child mortality. So we already have effective treatments for the common cause of acute critical illness and associated mortality. So we're not talking about ECMO in every center. We're talking about acute stabilization, fluid resuscitation, antimicrobial therapy, giving nutritional support, and respiratory and vasoactive support. So critical care is really an essential component of healthcare provision, and it does not have to be high-tech to be effective. In fact, we have simple, cost-effective solutions already. So in Malawi, implementation of ED triage and treatment tools improved care delivery and decreased mortality for a cost of $1.75 per patient. Implementing oral rehydration solution prevented death due to dehydration in sub-Saharan Africa and Southeast Asia for a cost of $75 per hospitalized patient. And implementing a hospital oxygen system prevented death due to pneumonia in Papua New Guinea for $51 per patient. And a study that we conducted in Malawi showed that bubble continuous positive airway pressure could prevent death due to severe pneumonia for a cost of $41 per patient. So the issue then isn't about a lack of having cost-effective solutions. It's really more about then potentially resource availability. And this is a study also done out of the Polisi group, this time led by Fiona Matala. And she surveyed 238 hospitals from 60 countries and asked about the availability of advanced and essential resources to care for critically ill children. And you can see on the y-axis is the proportion of ICUs who reported consistent resource availability. And then along the x-axis, kind of too small to read, but those are different bundles. So bundles to be able to provide basic infrastructure, monitoring, or respiratory support. And what's shaded in red here are the low and low middle income countries. And you can see, regardless of the bundle, that there's a huge disparity in resource availability. So ultimately what this means is that the issue is about implementation of available solutions as well as resource availability. With everything, of course, with all studies, there's strengths and limitations. And I think the real strength of this work is that it's the first series of studies that attempted to estimate the burden of critical illness in resource-limited settings. We had representation from all continents, regions, and country income levels. We also developed a novel definition that's applicable across resource variable settings. And I think we produced robust data to be able to inform policy level decisions. These are observational studies, however, so we're restricted to the available published peer-reviewed data in the systematic review and limited by site participation during the COVID pandemic and medical record quality and completion for the point prevalence study. And because of that, I think it contributed to some disproportionate representation. We're also limited to the reported cause of admission and death. And if anyone's done research on ICD-10 codes or has tried to fill out a death certificate, you know that there is a subjective component to this. And very importantly, this does not capture pre or post hospital events. This only counts children who have overcome all of the barriers to actually reach the healthcare system. And so it's important to mention that pre and post hospital events are important contributor to both morbidity and mortality in children in resource limited settings. So overall, I think this likely underestimates the burden of acute critical illness. We have more to come, lots that we're working on. As I mentioned, just because you say you have a PICU does not make all PICUs equal. And so we're working on developing an objective score to actually be able to categorize the available resources in a meaningful way. We plan to leverage the Global Parity Network to conduct interventional studies, as well as to test implementation of cost-effective strategies and determine long-term morbidity. We're also in the process, from a capacity building standpoint, of building a pediatric emergency and critical care fellowship in Tanzania. And the UCSF has a WHO collaborating center, and we're currently developing and piloting the WHO basic critical care course, which will be distributed widely. And so far, I've told you broadly about the work that the Polisi subgroup has done, which is a huge collaborative effort by many people. And I want to give you a little taste of the work that I do, because it takes this big picture and then really drills down more into the pathophysiology and how do we turn this information into improving patient outcomes. So I think there are a couple of key challenges in critical care medicine, and these are not unique in any way to resource-limited settings. They're just exacerbated in settings where there are limited resources. And the first is a prognostic challenge. How do we identify the child who is at highest risk of death or decompensation? If we have one ICU bed, who do we prioritize and who do we know needs that higher level of care? The second is a diagnostic challenge. So we want to provide targeted treatment, especially in the case of infections, because that can greatly alter the outcome. And I've hopefully shown you that infections still remain the highest cause of hospital mortality, as well as critical illness in resource-limited settings. And especially in malaria endemic settings, the issue that clinicians face is this malaria, is this sepsis, or is this sepsis because of malaria? So should I be giving antimalarials, antibiotics, both? Maybe it's neither, because it's actually a respiratory virus. And so through a series of studies on pediatric febrile illness, we're working to understand the etiology, as well as develop prognostic biomarker models in African children. And so we're leveraging the expertise across East Africa, UCSF, and the Chan Zuckerberg BioHub. We're using metagenomic next generation sequencing methods to identify pathogens in an unbiased manner. We're also testing if point of care biomarkers can predict bacterial infection and clinical deterioration. We're also exploring host pathogen interactions and developing ultimately a treatment algorithm, including these clinical signs and point of care biomarkers. There's two prospective cohort studies that are currently ongoing. The first is in Muhimbili Hospital in Tanzania, and that's led by myself and Dr. Sawe. The second is in Cholo District Hospital, and that's led by Dr. Annika Huth, who's pediatric emergency medicine faculty here at UCSF, and Dr. Gama Bandawe from Must University in Malawi. We're interested again in that non-pediatric population of children presenting with an acute illness to an emergency department. We're following the children from ED presentation to discharge or death, and importantly, following those children once they're discharged from the emergency department, recognizing that post-discharge mortality is actually quite high in resource-limited settings. We're interested in clinical deterioration and death, and each site has about 750 cases and 75 controls. So overall, this will be a cohort of children of 1,650 children. We started enrolling in Tanzania in July of 2022, and we're already halfway to our enrollment target. And enrollment hopefully will start in Malawi in this month. And I think the real richness of this study comes not only in the clinical data that we're gathering and the fact that there's different patient cohorts, but also in the fact that we're basically creating a biobank of samples. So we have both cases and controls that we're enrolling. For the cases, we're doing blood culture. We're also doing point of care testing on site. So we have developed the infrastructure to be able to test for C-reactive protein, procalcitonin, lactate, ferritin, hemoglobin, point of care malaria and HIV testing, as well as blood sugar. We're also able to do exploratory plasma biomarker analyses and metagenomic next generation sequencing on that plasma. We're also collecting whole blood, so we'll be able to do transcriptomics and really better understand what that pathophysiology is and that relationship between host and pathogen. If children have respiratory symptoms, we're gathering nasal swabs so that we can test them with metagenomic next generation sequencing. And if they have diarrhea, we're collecting a rectal swab. In Malawi, it's a slightly simplified collection, but still with the point of care tests, blood culture, and metagenomic next generation sequencing. So that's what's to come. And to wrap this all up and bring it all back into context, the key point is that more than 1 in 10 children who are presenting to resource-limited setting hospitals have acute critical illness. We also showed that there were 4 times greater all-cause mortality in resource-limited settings as compared to the U.S. hospitals. It's also important to mention that U.S. hospitals are by no means the gold standard, but it is something that we're familiar with. And hopefully I've made the case that critical care services are an essential part of the health system. The common causes of both critical illness and mortality have simple, cost-effective solutions that overlap with basic critical care. And unfortunately, global inequities persist. We saw that the highest estimates for both critical illness and mortality were in low income countries. So this is where we started. And I guess I'm left wondering, if we saw what the MDGs did, what will be the Sustainable Development Goal effect? So if the MDGs brought us from the left side to the right on this graph, primarily through preventive and primary care, how are we going to close the rest of that gap? And I think this is where the case can really be made for that hospital and specialty care, including much of what we do and critical care. And this is what I envision it looking like, integrating critical care into the acute care pathway. So if a child has an onset of acute illness, that's happening at the community level at primary care. And basic critical care means having the guardian or the first level provider understanding and recognizing a critically ill child, and then being able to refer them on. At the first point of contact at the clinic, being able to have the resources and knowledge to appropriately screen and stabilize the child, and then refer them and transport them to a higher level of care. On arrival to a hospital, we need to have appropriate triage systems in place to be able to prioritize the children who are sickest to get the care that they need. And then we start to enter into more advanced critical care concepts. So being able to provide actual pediatric resuscitation and a formal critical care unit that can provide organ support. So really the goal is to ensure that every critically ill child has access to the basic critical care services. And that we create these strong health systems so that we can refer and transfer patients to these well-resourced, more advanced critical care units. So to summarize, to decrease preventable child mortality and address global disparities, there's an essential need for pediatric critical care resources to be integrated into the health system. And finally, because I recognize that I am speaking to a room full of pediatricians and not necessarily global health providers, I just want to leave with the final message that geography does not have to be destiny, and that all of us sitting here can contribute to ending preventable child mortality. Global is local. So anything you do on any level, local, national, regional, or global, if you attack even one of these things, what you're doing is something that's part of the bigger picture and the greater good. So we can all do something to address preventable mortality. There's a lot of people to thank. Here's just a few of them. My mentors, of course, for supporting this work and providing guidance, and especially Jeff Byman for believing in that someone in critical care could do global health work as well. Very importantly, the Polisi Global Health Subgroup, as well as the Global Parity Investigator Network, both my collaborators, Raya and Joel in Malawi and Tanzania, and Annika here, and Gama in Malawi, and then of course the funding that has supported this work. So thank you all for your time and attention. I appreciate you coming. Happy to take any questions, comments. Except for from Maud.
Great talk. Here's a softball. What was the most, since the pandemic has ended, what was the most challenging or sort of one of the biggest barriers that you've had to overcome with all this research?
Just for the point problem?
Since post, yeah. For this work, because it's amazing. And you make it look easy, and I'm sure it's not.
Yeah, I mean, honestly, it comes down to resource availability. So I can illustrate this with a great point. We had the interest is there. We have within the network people who are physicians, scientists who want to take part in this research. And honestly, they did it out of the goodness of their heart. This was an unfunded study. But what we ran into were like real life logistical barriers. So many of these sites have records that are on paper. Many don't have a research infrastructure. So it was actually the physicians who were doing the chart review and extracting data from the written notes. And in one setting, there was such political instability that we were unable to get the data out of the country because the internet was shut down. So it's these barriers that, you know, transcend COVID and will continue to exist until major systems are changed and resources are injected into it, that I think will continue to be barriers in this work. Patrick.
Okay, so Bill Gates gives you $100 million, but not billion.
Okay.
How would you spend it today?
I think you know, I love intensive care units. Like, obviously I went into critical care, but I do think we have to start at the lower levels. So you have to start at the very basic, at that community level, and then work your way up. Because if someone doesn't recognize that a child is critically ill, if there is not a transport system that can take them to a higher level of care, you can have the nicest, most state-of-the-art PICU, and it's not going to matter at all. So before we can really capacity build strongly in that area, I think we have to work on those lower level community and first level providers. So that's education, basic resources. Hi, Sandrine.
Thanks for a great talk. I was wondering a bit about getting people to actually participate in the research, because it seems to me like they're under-resourced already. I suspect a lot of it under-resources isn't staffing. And now here you go and say, can you also do this? So how do you navigate that tension?
Yeah, you know, interestingly, the enthusiasm was high. In addition to the fact that there's no like clinical research infrastructure, there isn't also this concept of protected time in many places. So even if we had funding, the concept of buying someone's time down doesn't exist. Despite all of those barriers, honestly, the enthusiasm from the partners was very high. The benefit and what we've been able to hopefully provide is both additional experience. We were able to do some capacity building in terms of providing them with a data collection system, REDCap, all sites had that. And then to be able to participate and publish in this study. And then the hope is with the next round, we're actually able to get real funding from Gates to back this up, and then to really invest in the sites. Patrick.
Okay, so he really liked what you did with the education and putting together a better referral system. Now he's going to get $1 billion.
Oh, great.
What's the first trial you want to do?
Oh, wow. What do I really want to do? Like interventional? I'm still stuck on fluid resuscitation. Still think that we could do a better job of resuscitating children with septic shock. I don't think that we have it right for the patient population, but I also don't think that we understand what we're doing wrong. So happy to discuss more offline.
Any questions on the Q&A? Right. Thank you.
Yeah, thank you all. Pleasure to speak with you.